Okay guys, so the purpose of this video is discuss the oral station. You have to pass the oral station, 2 of them actually, for both your course practicals and for your national registry. The oral station is designed to evaluate your ability to verbally manage a patient from leaving your station all the way through to telemetry to the hospital. So you have to literally verbalize every single step that you're going to do. And that's one of the challenges of the station. One of the benefits is you get to actually take notes, and that's a unique feature of the oral station. We'll talk a little bit afterwards on how to process your notes so that it helps guide you through your call.
All right, welcome to the oral board station. In this oral station, you are responsible for all aspects of scene management and patient care for a given case. You will have 15 minutes to verbally complete a simulated out-of-hospital patient encounter. Remember that since we cannot see the patient, you must verbalize every action. I will provide assessment findings and other information only at your request. Conduct yourself as if I am the patient and ask me any questions you would normally ask a patient in this situation. I will also play the role of bystanders or other healthcare providers. Verbalize all interventions, ask any questions, and verbalize any orders you would normally give in the field, just as if this were a real call. Throughout the case, assume that medical direction grants permission for you to perform any interventions you request. The makeup of your crew will be explained as part of the background information you'll be read in a few moments. You are the team leader and are responsible for directing the actions of your assistants. They will not do anything without your direction. I will acknowledge your interventions and may ask you for additional information if needed. You will also be required to complete a simulated radio report of this call, just like you would in the field. I will act as the receiving facility whenever you are ready to contact them. Throughout the case, you may take notes. Paper and pencil are provided for this purpose. At the completion of this case, leave all of your notes in this room. Please remember that you are not permitted to discuss any specific details of this station with anyone at any time. Do you have any questions?
No, but before we begin the case, I'm going to take just a moment to make some notes.
Go ahead.
Okay, I'm ready to begin.
Okay. Your 15-minute time limit will begin as soon as I hand you the case.
Understood.
Please read this information out loud to me and be sure to return the case before leaving the room.
Will do.
All right.
You are a paramedic on a transporting paramedic unit. You are working with a paramedic partner in an urban EMS system. You are 10 minutes from the community clinic and 15 minutes from the closest emergency room. At 13:20, you are dispatched for a chest pain. It is a clear summer day with a temperature of 110 degrees Fahrenheit. As you arrive at the scene, you see a man sitting in a chair. Okay. So I'm going to proceed immediately from the station under Code 3 conditions, considering due regard all the way from the station to the call, stopping completely at all intersections and making sure that there's no danger on the way. When I arrive at the station or at the scene of the call, are there any things that I need to be concerned about in the local environment?
No, you arrive on scene to find a single family dwelling,
Okay.
well kept with no access issues.
Okay. All right. And I'm going to maintain BSI throughout the call. Okay. All right. So I walk into the residence. What do I encounter?
Upon arrival, the visual appearance of the patient is that he's clutching his chest in obvious pain.
Okay.
He has pale skin, and he appears slightly short of breath.
Okay. Hello, sir. My name is Mark. I'm a paramedic. My partner are here to help you. Can you tell me what's going on today?
The patient states that he's had slight pains over the last month, but has not seen anyone for them.
Okay.
Today, he was watching TV when this pain came on and has not gone away in the last 20 minutes.
Okay. All right. Okay, so sir, just to confirm, your chief complaint is chest pain. You're having trouble with your chest today. Is
Correct.
that correct? Okay. Have you ever had this kind of pain before?
This pain has gone on for the last month, but it's been very slight on and off. I haven't seen a physician for it.
Okay, and is there any history in your family of this similar kind of a thing?
My father died at age 40 of a major MI, and
Okay.
my older brother had a cabbage 4 separate times at
Okay.
40 years old.
Okay, and just confirming, sir, what's your age?
My age currently is 40.
Okay. I'm going to ask my paramedic partner to set up vitals. In the meantime, I'm going to run through a couple of things to make sure I understand what's going on with my patient. My patient's talking to me, so he has a patent airway. Is that correct?
Yeah, patient's answering in full sentences.
Okay, excellent. I understand patient's skin signs are pale, cool, and diaphoretic.
That is correct.
Okay. Any cognition issues for my patient at all?
No, the patient is fully aware and cognizant.
Okay. All right. Based on what I know so far, the fact that I have a 40-year-old male with chest pain and the fact that he has a familial history of chest pain, I'm going to treat this as a priority transport, and I'm going to be transporting to the emergency room because they have a cath lab available to them.
Okay.
All right. I'm going to put them on oxygen. Let's start with a nasal cannula at 4 liters per minute, and then we'll check and see how well they're oxygenating and make adjustments if necessary. I'm also going to give my patient 325 milligrams of chewable aspirin and ask them to chew it up and swallow it. While I get a full set of vitals, I'm also going to do an ECG, including a 12 lead, to make sure I know what's going on with this patient.
Okay.
Okay. So, sir, we're going to put some oxygen on you, help you breathe a little bit easier. Also, I'm going to give you 4 chewable aspirin. Please chew these up really well and then swallow them for me. Do you understand?
Yes.
Okay. All right. Can I get a full set of vitals from a patient, starting with skin signs?
Skin signs are pale, cool, and diaphoretic.
Okay. And my patient's blood pressure?
Blood pressure is currently 150 over 86.
Okay, 150 over 86. And pulse?
Pulse is 84 and regular.
Okay, 84 and regular. And do we have an initial SpO2?
Currently, the SpO2 on room air was 94%. With
Okay.
your oxygen administration that you had stated, we are now to 96%.
Okay, so I'm going to shoot to maintain an SpO2 between 94 and 98% throughout. Okay, how about respiration?
Respirations are 22.
22. And lung sounds?
Lung sounds are clear and equal bilateral.
Okay. How about pupils?
Pupils are pearl.
Okay, and a finger stick?
Finger stick is 126.
Okay, and do we have a temperature?
Temperature is not available.
Okay, so we're going to go ahead and hook the patient up to the monitor to do the initial ECG followed by a 12 lead. What's my initial reading on a 3 lead?
The initial ECG is a sinus rhythm.
Okay, and when I put on the 12 lead, what do I get?
The results of the 12 lead show ST elevation in leads 2, 3, and AVF, with ST depression in leads V2 through V4.
So based on the fact that my 12 lead is showing ST elevation in leads 2, 3, and AVF with corresponding depression, I'm going to treat this as a possible inferior MI. That means I'm going to use nitroglycerin very cautiously throughout. Prior to doing any other treatments, I'm also going to establish IV access, large bore, and I'm going to initially set it at a TKO rate, but I'm going to be ready to give a fluid bolus if my patient's blood pressure declines.
Okay.
Okay. Sir, have you ever had nitroglycerin before?
No, I have not.
Okay. I'm going to give you this tablet, and I want you to put it under your tongue and let it dissolve. Don't chew it and don't swallow it.
Okay.
I'm going to recheck your blood pressure a couple minutes after we give it to you, but this should help with your chest pain.
Okay.
Okay? So I'm going to go ahead and give my patient the first dose of nitro and be prepared to evaluate the blood pressure and the response very cautiously because of the fact that it's an inferior MI.
Okay.
Okay? So I'm going to be treating my patient as if they're unstable, which means I'm going to be rechecking vitals every 5 minutes. Sir, we're going to go into the hospital. We'll do the rest of this process en route. Are you able to stand up and sit on our gurney?
Sure.
Okay. So patient sits up. We place him onto the gurney. We put him into the back of the ambulance, and now we're going to proceed rapidly to the ER. After we get en route, we're going to do a recheck on vitals. So I'd like to get a new blood pressure. Is it still?
Blood pressure is still at 150 over 86.
So, sir, did that first nitro tablet help at all?
Yes, my pain is now an 8 on
Okay.
1 to 10.
I'm going to go ahead and give you a second nitro tablet. Go ahead and do the same thing. Put it on your tongue. Let it dissolve. Okay? All right. Any other changes in my vitals?
No other significant changes.
Okay. All right. So my differential diagnosis for this patient is that they are having an MI. It looks to be a STEMI based on the 12 lead. All right. So I'm ready to give my telemetry report to the hospital.
Okay, go ahead, and I will act as the hospital during this component of it.
Okay. All right. So ER, this is Medic Unit 3236. How do you read me?
Medic Unit 3236, we read you loud and clear. Go ahead.
I am presently en route to your facility with a 40-year-old male with a chief complaint of chest pain. We're approximately 10 minutes away from your facility at this time. Okay. We have the patient on O2, a nasal cannula at 4 liters per minute. We've been able to maintain a saturation point between 94 and 98% throughout. We've administered 325 milligrams of chewable aspirin. We have a large bore IV access established. We conducted an ECG and a 12 lead, which initially showed normal sinus rhythm and ST elevation in leads 2, 3 in AVF, and corresponding depression in leads V2 through V4. So we are treating this as a possible STEMI. We have cautiously administered nitroglycerin. We gave the first dose after having a blood pressure of 150/86. No change in the blood pressure and a reduction in pain from 10 to 8. So we cautiously gave a second dose, no change in the blood pressure, and that brought the pain down to a 6 on a 10 scale. Are you ready for the rest of my vitals?
Please proceed with vitals.
Okay. Skin signs are pale, cool, and diaphoretic. I already mentioned blood pressure of 150/86. Pulse is regular at 84. SpO2 I mentioned originally was 94%, currently 96%. Respiration's 22. No labored breathing. Lungs are clear. Pupils are pearl. Finger stick was 126. Do you have any other questions or order for me at this time?
You may proceed at your discretion with the third round of nitro as long as the blood pressure remains stable. Please shoot to get the pain scale down to a 0. Please remember you have morphine as an option after your 3 rounds of nitro.
Repeating your orders, I'm able to give a third dose of nitro as long as the blood pressure remains stable. If it drops, I'll give a fluid bolus. Also, my goal is to maintain pain down to 0 on a 10 scale, and I can use morphine if necessary.
That is correct.
Okay. Do you have any other comments or questions for me?
3236, no other questions or directions.
We'll see you in approximately 10 minutes.
Copy.
And I'm done.
And would you like to add or change anything?
Not at this time.
Okay, thank you very much, and please pass back the scenario.
Thank you.
Thank you.
Okay, so let's talk just a little bit about how that went. I remember I said to take your time, and I took my time, and we still had time left over. 15 minutes, if you're an organized person, will give you plenty of time to finish this station. Right? Now, we had a chest pain, and as it turned out, we had an MI with a possible inferior STEMI. So you'll notice because of that specific differential diagnosis, there were a couple of things that I did. Most importantly, I made sure that I had a good ECG reading before I decided to give the patient nitro. Once we found out that it was inferior, that was even more important to have done that. You also notice that I did so cautiously, and I reiterated during my telemetry report what the initial blood pressure was, as well as any change in the blood pressure, so that the ER knew that I was aware of the cautious nature of giving nitro with an inferior MI, and that they felt good about that decision. You also notice that I made sure that as soon as I felt like I had a chest pain and a family history that was cardiac in nature, I put the person on O2, but because they were breathing adequately, I started off at a nasal cannula. Remember, our goal these days is to maintain an SpO2 between 94 and 98%, and we're able to do that with the nasal cannula at 4. Now, if my patient was having more difficulty breathing, or they weren't responding well to the nasal cannula, we can easily switch to an NRB and bump it up between 10 and 15. That's an easy fix. Also remember, when it comes to a suspected MI and chest pain, aspirin right after that O2, that's the thing we want to give. Sometimes we get focused on the nitro and the morphine, and those are important tools in our tool bag, but we gave that aspirin right away. We got our full set of vitals. Then we took a look at the EKG, and then we gave the nitro. In the next video, we're going to talk about some tips that you can use in any oral board station to help you be successful.